to recording process. Very good. Welcome to this session, a kind of educational workshop, whatever we want to call it, on P53 immunohistochemistry. So P53, this is a session I wanted to do because in pathology, we are going towards a very heavy use of molecular pathology, and molecular pathology data becomes more and more important. And I wanted to discuss with you the use of immunohistochemistry for molecular data. And of course, we are pathologists, morphologists, so we like to see these mutations. And, for many, many years, BRAF B600 antibody was my favorite antibody. I could see the mutant protein. It was amazing for me. But also, it gives you a picture of the microenvironment. And in many pathological conditions, the microenvironment is very important. You don't want to grind it. You want to know which mutations are in which position in the tissue. So P53 is an antibody that has been around for many, many years. It's one of the oldest antibodies that we had at our disposal. And we kind of never really understood it until more recently, out came the concept of mutant pattern and wild type pattern. So I'm kind of really excited, and Adelina's prepared this presentation for us, and I hope we will all learn something. I'm sure I will learn a lot, and we need to take it as the first step to evolve this concept of molecular pathology done with antibodies.
Yeah, so like Corrado says, P53 is actually one of these next generation immunohistochemistry markers that was a bit ahead of this time, because we're trying to recognize these mutant patterns that are, let's say, a little bit more complicated than just looking at BRAF immunohistochemistry, where we see positivity wall-to-wall in the cytoplasm. And it was ahead of its time because at that time, immunohistochemistry was not very well optimized. It was used in research. We thought different things about B53. So let's...
And we had different antibodies that hit different bits of the molecules, and nobody really understood very well why sometimes it was staining, sometimes it wasn't staining.
We will touch upon that because there are antibodies that bind different sites. So this will be interesting to see. And I know this is corny, a bit corny, but P53 deserves this kind of designation of the guardian of the genome, because it basically protects the tissue from going astray when it's exposed to all sorts of stressful, whether they're normal, very common stressors or not. And it's interesting because P53 gene is not that large. It's definitely most studied because it's the most commonly mutated gene in cancer, but has an incredible complex function with many functional areas, or more exons than other genes have on average. And also the mutational constellation is also very complex, and I think the most the most numerous mutation described in P53. And I want to say from the start that the correlation with the IHC and the latest studies using different sequencing methods show that is good and has an excellent specificity. Therefore, if we recognize a mutant pattern, that means that we are sure that there is a P53 mutation.
As sure as possible, because
99%.
Yes, but we are pathologists, we go on percentages. When something is 90%, we are kind of good, 95% excellent. We wish we could be 95% accurate in our diagnosis. So yes, so tell us, so I was just going to reflect on something, is the most commonly mutated in human cancer, and what does this tell us? It tells us must be a very fundamental molecule, because otherwise, why everybody gets busy to be mutated, to have a mutated P53 before they develop cancer? Yeah, so that's a kind of context for this. Cool.
Yeah, absolutely. But what I wanted to say is that the specificity is not as good. However, now that we recognize more and more these patterns, we're becoming better at picking up, or at least calling the case indeterminate and saying that, you need to test it by molecular studies and check the P53 status by using molecular studies. And Okay, this is just to show a bit of a
I-
timeline.
I was in the same research institute as David Lane when he was in Dundee,
Yeah, so
still waiting for a Nobel Prize.
still waiting.
Still
Yeah.
waiting. Okay.
Yeah, I think P53 was bound to be discovered by kind of multiple groups that identify the protein. And initially it was thought to be an oncogene. It was thought to induce cancer, but then subsequently it was Bert Wolkenstein's group who actually discovered the tumor, that is a tumor suppressor, in fact. And then this was followed by the description of the P53 related syndrome of germline P53 mutation, Li-Fraumeni. And also I put here MDM2 because it's probably one of the most important proteins that interact with P53. And I'm just going to show how a bit later. So I think we went from oncogene to suppressor. And then I want you to think of P53 as a transcription factor that normally is bound to this MDM2 in a resting state. And that's why MDM2 is very important, because alteration in MDM2 can lead to abnormal P53 function. But what P53 does is becomes a tetramer and it binds DNA and induces the transcription of other proteins, other genes that do all this, basically arrest the cell cycle, lead to apoptosis, to senescence. So basically it kind of regulates the cell response or the normal mitotic, let's say, galore in stress conditions, including whether they're inflammatory, whether they're, induced by radiation or other factors. And this is to show how P53 regulates its own level of protein in normal cells, which should be low. So, and we see that by immunohistochemistry, and I'm going to show in a minute, it's usually weak to moderate expression and is either scattered around or it has some sort of gradient according to the stratification of we see that in epithelium, don't we?
The position of the cells in an epithelium, yeah.
And basically P53 induces the synthesis of MDM2, which binds it in normal conditions, but then through stress is actually a complex ATM that phosphorylizes P53, which induces the detachment of MDM2. And then P53 translocates into the nucleus, and then basically it increases its expression and effect on the cell cycle and cell biology. And I just want to go as fast as possible to the immunohistochemistry, because we need to first focus on this normal or non-mutated P53 expression, because we say normal because that's the expression in virtually all tissues, right? But then the same pattern we see in benign tumors or other, usually in low-grade malignancies. And this is what I was saying earlier, because depending on the structure of the tissue, like for instance in fallopian, we see scattered. Again, the intensity has to be weak and moderate. Rarely we see strong staining intensity in normal, or it has a gradient of fewer and fewer cells and lower intensity as we go through
expression
the surface.
So there must be a reason why these cells express P53, maybe in response to some stresses, some DNA damage, etc., etc. But then eventually they repair whatever it has to be repaired. So then the expression, the amount of protein tails off, and you have restitution of function and continuity.
Yeah. So the more normal the tissue is, the lower the expression you expect.
Okay.
So these are some examples.
But here you're introducing this concept wild type pattern, because then there is mutant pattern. Yeah.
Yeah.
So I think this is the most important message, is that we're always used to immunohistochemistry to say how many cells are positive, what's the staining intensity, and then we have some threshold, more than 30% means this, less than 5% means this, etc. But now the game is different. We are looking at patterns and say, this is the pattern of the mutated protein rather than the wild type protein. So you can have wild type protein, and which has implications to interpret the changes, but then the presence of a mutated protein means something in oncogenesis, in tumor evolution, perhaps in dysplasia, perhaps in grade of carcinoma, etc., etc. Yeah.
Yeah.
So this is the most important concept now is we should, for some things, we should go away from counting and assess more the pattern. Luckily, yeah. Okay.
So this is just to show a few examples. So the H&E, this is I chose this on purpose because it has some staining artifact here, but the tissue is normal. We don't see any dysplasia, any tumor in here. And this is the usual wild pattern. So this is at most moderate, even at this magnification. Yeah. And then we see weaker nuclei kind of crippling up.
And it seems to be activated, it seems to be expressed at in the basal layer of the epidermis.
Yeah.
And then it kind of...
But even in the basal layer is skipping cells, so it's
the cells in the epidermis.
And this is very important for one of the special mutation patterns that we're going to see. And this is actually a benign proliferation. It was thought to be a mesothelial tumor, but it was only microscopic. Mm-hmm. And it's kind of reactive mesothelial proliferation, and this is the lower power. This is to show that the wild type pattern can be as weak as this. So basically 2 or 3 cells. This is a bit of dirt here. It's a space.
And they are staining very weak.
Yeah, weakly. Maybe we have here.
So perhaps we should say P53, because of its nature has been as a transcription factor, localizes to the nucleus. So the staining is nuclear.
Yeah.
Yeah. And this picture must be meaning that this proliferation of this neoplasm is not really activating the P53 pathway for arrest. It doesn't need to repair anything. It's just kind of ticking along nicely. Okay.
Yeah. Now, again, this is wild type pattern. So whenever we look at wild type pattern in tumors, we can't 100% exclude the presence of P53 mutation. But this is obviously something incidental, is an enfolding of the mesothelium.
But what you're showing now is that, because just to preempt a little bit your presentation, but one of the mutated pattern is complete absence of staining.
Yeah.
And then the interpretation, you see here, you see a few staining nuclei, which means actually the protein is there wherever is needed, rather than being completely absent, which is not absent, actually is absence of staining, which has a completely different meaning. Yeah.
And in this situation, it's good to understand that there is staining in the tissue, because if the tumor cells, so-called, were all negative, then we need to have internal control. But we'll talk about this a bit later. So this is a little bit more, let's say, excited kind of
very busy, I would say,
epithelium. So this is a bladder, and it's definitely, I mean, we can argue that this could be hyperplastic.
Yeah.
But then this was inflamed as well. And I think this patient had radiation actually after, I think it was just for other reason in the pelvis. But you see again the same gradient. So maybe here the proportion of the nuclei is much higher, the proportion of staining nuclei. But again, we see that, and the staining intensity is at most, let's say, moderate to strong. But then you see it fading.
It varies. There are weak staining cells and stronger staining.
I don't think we even see like a tiny clone or of cells that are alike.
So interpretation of this would be, well, there is activation of P53. It must be there because maybe the tissue was irradiated, as you said, or something like that. Is trying to repair. But this is not an indication that there is a mutation in P53.
And I think, do you think it would be wrong to call this overexpression? Because it actually...
Yes, but
that's what it does.
That doesn't matter.
But the reason is reactive.
Yeah. Okay.
And then, like you were kind of prefacing this kind of continuum between normal and abnormal, and the attention we need to pay to patterns. Now, there is so-called the P53 signature that has been described under this name in fallopian tubes when it was thought it was the precursor of serous carcinoma, but now people have moved away from it, and also in the esophagus. But we see this kind of P53 mutation, or on IHC, we see evidence of a certain P53 mutated clone in other places. And this is defined by a mutated pattern that is localized, usually it's very localized by IHC, but in the absence of dysplastic changes. And this is a bit tricky because, for instance, in esophagus, you might have a case for second opinion from a pathologist who put P53, and you would look at the morphology and say, well, actually, it's not dysplasia, is it? And then you will need to interpret it.
But the P53 could be mutated.
Retrospectively, yeah. And then,
okay, so can I say something? You know, the P53 signature obviously has been with us for a little while. As you say, it started off in the fallopian tube epithelium. If you remember, it was associated with some carriers of particular mutations, etc., etc. So we looked at these little clusters of cells, and because at the time you would not have seen these cells if they were not staining. The P53 signature usually is overstaining of P53. That's what it is. You know, it's a cluster of cells on a background for the rest of the fallopian tube epithelium that doesn't really show very much. You find these clusters of 10 cells, 5 cells, or 20 cells. They stain really, really strongly. Yeah. And I think the same happens in the esophagus, although it could.
Yeah, it was a thought at some point that we should basically stain all of them with P53 and P16 to kind of provide additional prognostic in the absence of dysplasia.
It must have been somebody like me that teaches physical chemistry all the time. Okay, this is your an example of the clustering of staining.
So this is a fallopian tube, the classic P53 signature site. And if you look, I can't tell the difference between this epithelium here, for instance, and this here. To me, they look the same. Here looks a bit more cross-cut, but if you look carefully, there's still those clear cells, PEG cells. It doesn't, the structure is not very different from, it's not different from normal. And then,
but with this staining, we're identifying that there are patches on the epithelium that are probably carriers of this P53 mutation, of a P53 mutation.
What that means, we're not very sure. So it seems like it's not as important as we initially thought, at least in fallopian tube. So this is an example in the skin with the small clone that looks like it's P53. It could be P53 overexpressed, but it doesn't make sense.
But usually if you receive an insult, it's very difficult for a DNA insult to be limited in such a very, very small area. Think about UV radiation, etc., etc. It's kind of probably this is a signature rather than a reaction to damage.
Yeah, exactly. And I just want you to know that the epithelium is normal. And here is a bit of inverted. Now, there have been wild type patterns that are spare the basal layer completely, but this is a bit too, it's almost all cell staining. So this is between P53 signature and a odd wild type pattern. At the same time, there are no evidence
of dysplasia,
sort of dysplasia or reactive changes that would explain overexpression.
So it is clear that there are still certain examples, certain conditions, as the situations where we don't really understand very well what is happening. But for instance, think about the fact that skin, the epidermis has got two pools of, if you want, reserve cell and stem cells. One is in the interfollicular epidermis, so the basal cell layer, and those are the cells that are thought to give rise to actinic keratosis. And then there are the reserve cells in the follicular infundibulum, and those are the cells that are thought to give rise to Bowen's disease, which is a kind of, there are two different dysplasia. Actinic keratosis goes from the basal cell downwards and buds into the dermis, and instead the Bowen's disease colonizes the epidermis, and the kind of two different diseases, of dysplasia of the squamous cells. Okay.
This is a bit debatable because
this is debatable, yeah.
So morphology, there's this odd hyperkeratosis, and one might argue that this is dysplastic. And this was a null pattern, which is, we'll see a bit later, is when Corrado already mentioned it, that is when you have absolutely no
That's absolutely same. So I think this is an important pattern and this is the reason why for a long time this gene was thought to be an onc gene rather than a tumor suppressor gene, because in many occasions, rather than accumulation, you had loss. So you the signals were confusing.
And if the assay was not strong enough, then even the wild type would have been negative.
So this pattern, if this is complete loss, and you would think that somewhere there will be a cell that expresses P53 in the epidermis. If there is complete loss, the implications are that this molecule has lost, the protein has lost the bit that the antibody react to. So there is a truncation, which makes it transparent to immunohistochemistry.
Yeah, it's not as easy because there are different types of mutations that lead to loss. But of course, the most easy, intuitive way of thinking is that the protein is badly damaged in a way that is not recognized anymore.
Yeah.
And then I put possible dysplasia. And now to kind of shift to the actual P53 status in disease and the mutational patterns. I mentioned this previously, but P53 has 11 exons, so it's more than the average, your average gene. And given the small size, it's even more impressive. And it has a few important domains, like this one, the transactivating domains. There are two, and one of them is where a P53 protein is basically recycled, if we can say so.
Ubiquitinated, is ubiquity inside. So this is to degrade. And so, because one of the characteristics of mutant P53 is that it loses, the cell loses its ability to degrade it because the ubiquitin band inside is not functioning very well.
So obviously mutations in this or any site that would induce a conformational change that would obscure this transactivating domain, obviously, it would lead to the accumulation.
And here is why in a mutant pattern, we see this very, very strong staining, which normally, even if a cell is very upset and it needs to repair DNA and therefore stop the cell cycle, it doesn't never really get to be black.
These are most point mutations, but we'll see again in the that induce this in accumulation of the protein. And then this is the main site of mutation. And there are point mutations, most of them. And again, they obscure this site usually. And then this is nuclear localization domain, and it's very important for the cytoplasmic staining again, because it prevents the protein to translocate in the nucleus.
So that's a really very, very important point that I think we need to focus on. So normally, even in cells that overexpress P53, if P53 is not mutated, you don't really see staining in the cytoplasm. But when you see cytoplasmic staining, it's almost a telltale sign that there has been something wrong with the nuclear localization domain, so the translocation into the nucleus doesn't happen, and therefore you stain the cytoplasm, and that's where you stain it.
And
so even if you find, there is no nuclear staining, but the cytoplasmic staining is a telltale sign.
And a note would be that cytoplasmic staining can be very focal. So you might have a big chunk of the tumor completely negative, and
I think these are the nuances that we need to learn, and understand more. When can you stick your neck out and say, well, I think this is a mutant pattern. How much you can rely on this.
So I think we've already went into this. So Corrado is talking mainly about this, the biggest chunk of mutation, which is like 60–70% of a P53. They're usually point mutation that lead to a difference in the protein 3D structure, and these lead to accumulation of P53. These are the two. By the way, the functional effect is completely, it's not being induced by the category of the mutation. So missense mutation can have any functional effect on the protein. Then you have frame shift and nonsense, that these can either show cytoplasmic or no staining. And frame shift comes from change in reading frame. So it can lead to either a smaller protein or a non-functional, so it has all sorts of effects. And nonsense is usually when you have a very small protein that is non-functional, is usually associated with no staining. And this is what Corrado was saying previously.
Yeah.
And then...
And also remember that because P53 is a multifunctional protein, some of these mutations may affect one function but not the others. And actually some of it are gain of function as well. So we were discussing how to recognize mutant pattern, but we cannot tell from the staining what is the effect on the cell, what kind of function
and this
is
could
lost.
be important. I mean, we use IHC, and we will show you some examples for diagnosis and prognosis, especially for molecular classification. However, the function of P53 would be very important if we were to develop, for instance, therapies, because a certain IHC pattern is not equivalent to a particular P53 function or change in function. So that means we're using this just to recognize the pattern and understand what diagnosis we can make, how we should comment on the case, how should we classify it, but only in relation to other alterations.
So I look forward now to some of the examples you hopefully you will give us, which are in the context of particular pathological conditions, I guess, and how do we interpret these? Yeah.
Yeah. So
fantastic.
These are just to illustrate what we've already talked about. The missense mutation associated with a missense mutant pattern, which is diffuse positivity, but I will go through each one of them. And again, we see the strong staining intensity. This shouldn't be. Once we see strong staining intensity, I think we already need to be alert, regardless of the overall pattern. And I'm going to show you some special mutated patterns that demonstrate this, actually. This is the complete absence of staining, but I'll magnify the image to see the internal control. This is the cytoplasmic staining pattern. So these are the three main patterns we're looking for: the missense, the diffuse absence of nuclear staining, or the cytoplasmic staining. This is quite diffuse here.
That was an excellent and easy to interpret slide, I must say. Sometimes the cytoplasmic staining is difficult to pick up.
Yeah, so this is just the explanation of what Corrado was saying before, that this is one of the reasons it was thought that this is the accumulation of P53, which does bad things for the cell, but is in fact the non-functional usually or poorly functioning protein that accumulates in the nucleus. And we see this pattern.
You can understand the conundrum for the scientist that looked at a putative oncogene of some kind which accumulates in tumor. How can I call it tumor suppressor?
Exactly.
Surely, because a tumor suppressor gene by definition is P10, but P10 is lost. It makes sense. So P53 never really made sense at the beginning.
Especially this large category of, and again, the pattern. And when I was preparing this presentation, Corrado actually told me, you need to see this, or you need to emphasize this, that the uniformity of staining, whether it's moderate to strong, is very important to recognize this pattern, as opposed to, so this is actually a breast cancer, just to introduce the idea that it's not only ovarian or, endometrial or gastric cancer, that actually metastasized, and it was almost misdiagnosed as an ovarian primary. But the primary tumor had P53 mutation. It had missense pattern. Now, the null pattern, this is what we've already said. That is the second most common. I'm not sure I said that. And the protein is usually very disturbed in a way that is not recognized by the antibody. So we see the internal control between the tumor clusters. It's not very strong, obviously, because it will have a wild type pattern, the normal cell.
I can really see that there are.
I think there's some dirt here. I apologize.
Yeah. And it's interesting how every tumor cell does the same, the uniformity. This seems to be often not a mutation in little areas, although I'm pretty sure you will show us some examples where there is
I'm pretty sure there could have been this area with complete loss, and then the rest of it wild type pattern, and then good luck in recognizing that. Again, it's not a specific mutation, like I said, especially for these other two patterns. And what we need to make sure is that the background does not stain, because if we see cytoplasmic staining in the tumor, but then the rest of the tissue is also, we need to have this clean
so that's
staining.
Clearly, yes.
And then, of course, now the question is, and we show some examples that are in between, there are some patterns that are difficult to classify, so we cannot be sure as pathologists looking at an IHC slide. And there are two main situations. One of them is when we have overexpression of P53, but we're not sure if it's mutated pattern.
Yes, or sometimes we see a lot of staining, but not quite entirely all of the cell staining. And maybe some little bit of variation in staining intensity. And you think, is this overexpression because of just functional overexpression, or is this mutation? So that's difficult sometimes, I agree. And then the second point is when you have little areas that show mutant pattern and areas that don't show mutant pattern.
Yeah, and it's very difficult when you have wild type combined with lost in particular. It's easier to see when it's overexpressed.
So these, we need to understand that this situation will occur. Usually, the P53 mutation usually is something that is pervasive in the tumor cell population, but not always. So again, as pathologists, people accuse us of being superficial because we are happy when 80% or 90% of the cases fit the pattern, and we'll go along. What about the 10%? Well, I don't know. We'll put it aside and think about it.
We need help. And then I just put this with the possible subclonal population, because this is actually an ovarian cancer that has metastasized to the axilla, which is not very uncommon. Alert breast pathologists.
Yes.
We're going to focus on these two annotations that show different populations. So the first one has, I think we can all agree that this is wild type pattern. There's internal control. There are cells weakly to moderately staining.
But when I looked at this picture, the staining intensity of these cells is such that one almost say, is it real staining? Because
I think some of them are beyond that.
Maybe,
I would say that some of them, look at this one, for instance. This one
is a little bit darker. But maybe it's because this slide has got heavy counter staining, and therefore you look a little bit of this bluish, brownish thing. But anyway, I take on board.
Would you not consider this to be staining? Wild type?
Yes, I think following your line of thought, yes, I think this could be.
It could have been two cells, and it would have, we should have said wild type in it. But this area, this whole nodule was only had internal control, and the tumor cells were actually negative. So now this poses the question. This looked like a high-grade serous carcinoma, by the way. It had lots of mitosis, and it's possible that has a clone. We know that low-grade versus high-grade.
There may be heterogeneity. There are tumors with heterogeneity. So I would say, looking at these pictures you're showing us, one improvement I would ask our laboratory to do is go easy on the counter staining.
Usually go easy, I would say.
I'm just saying, that could be an improvement we could.
To be fair, I prefer these ones.
Because why? Because you are telling us any amount of nuclear staining is important. So it's
wonderful because then I can see.
So I don't want to be in a position where I look at it and I say, well, I'm not sure that this is counter staining or is it real staining. Okay.
Okay, that takes us to the importance of controls, and I want to go fairly quickly through this. And I think the most important thing, and we were making this mistake in the past of putting a very positive tumor with missense pattern.
Yeah.
That can have very high levels of P53, and then our assay was under-optimized.
Yeah.
So then the most important, you can put a bit of small bowel, appendix, tonsil, whatever you like to do, but also make sure your internal controls, so whatever you have stromal cells in the tissue stain as well in the
You
test.
should have some staining. So your message here is, you know, I mean, this business about the on-slide control having 3+ staining intensity is a inheritance of the past, isn't it? Like UK NICVAS was saying, you need a strong, but also they said you need a moderate and a weak, you know, and then everybody focused on the strong and forgot the weak.
Yeah.
And the weak is the most important because the weak is the one that will fall off the shelf before anything else when you underperform.
And that's also the inheritance of the markers we used to use, because most of the diagnostic markers are not as sensitive, let's say.
Yeah. Okay.
So in any case, just to show this wild type pattern again that Corrado maybe doesn't want to see.
No, I can see that. And this is also in the right area.
Exactly.
You know, whatever you choose, whatever part of the guts you choose, it needs to be in the area that is patterning. In this particular one that's where the proliferation fraction is.
Yeah, in the crypts. So not really on the surface epithelium, you shouldn't see any cell. So these are the controls we usually use. We do have a mutated protein. The problem is when you have problems, you need to understand the stain at all, or how bad is it.
Yeah.
Now the discussion about antibodies.
Yeah.
There are these two clones that are recommended because what they do is they bind to this highly conserved N-terminus site, which is recognizes human, mouse, all sorts of, especially this one. But D07 is the one we use actually. And there are other antibodies that bind at the site, C-terminus specific, and now they've developed even specific mutation specific for P53.
Exactly. Yes.
And they use it in all sorts of things, not only immunohistochemistry, even imaging or.
Yes. So this is an important message. It depends what antibody you use. You will see different staining patterns according to different mutation, because obviously if I don't use an N-terminus antibody, I will much less likely find a null expression because the first part of the protein is preserved and I'll stain it.
Exactly. This is somewhere between 20 and 25th antibody, but they're C-terminus antibodies. And obviously when you have a truncated protein, this would be more difficult. And then this is what we said before.
And again, you know, at the beginning, all these things were not really very well described. And so there was this notion that immunohistochemistry is not the right tool to investigate this condition, this protein, because some antibody stains and some antibodies don't stain the same tissue, where I can demonstrate overexpression, I can extract, I can run gels, it's there, and then this antibody doesn't stain. But then the same antibody stains another tissue, it's not the same protein. So there was a lot of confusion over these matters at the, you know, in the early days.
Yeah, this is just to say that obviously it's mostly suboptimal rather than, and again, we already discussed this, that use a normal bit of tissue that is adequately fixed rather than trying to use.
What about cell lines?
Cell lines, but is it a good use for P53 though?
I don't know. I was asking the question. We should ask our friend Colin. Is there a P53 cell line?
If we think that you know, the last, you know, kind of intensity difference that not even the human eye can perceive is important, and then you want to optimize.
Maybe. Or maybe these providers of cell blocks, you know, cell lines for on-site control may think about providing cell lines with specific mutations, and then you can have an array of these mutations with a different antibody, and you can control, and you know what mutations you're looking at.
Sounds like it's more expensive than the
because you were thinking that now there are more and more mutation-specific antibodies where we can home on particular mutations.
Yeah.
But this is
it's just
not here yet.
yeah,
So,
you would think it's a matter of course, but who knows? Maybe we'll go back to IHC entirely. This is just a tonsil, and I think the current criteria
that's
is,
our friend. We always use lymphoid tissue for everything.
It's based on, 20% germinal center cells, weak to moderate, and then less than 10% in the interfollicular areas, mantle zone. And this was a summary to kind of describe these patterns, the wild type pattern, the overexpression, which is in between, and then the 3 main mutant patterns. Now, this is again summarizes the fact that wild type pattern is seen in normal and in low-grade neoplasias, whether in situ or invasive, normally. But don't be surprised if, for instance, you have low-grade dysplasia and you do P53 and you find a mutant pattern, because that's not uncommon. Now, these are the things we're talking about, that we're going to focus on diagnostic and prognostic kind of input from P53. Now, reason to use it obviously whenever we have the absolute size of the specimen too small. That's always a good indication for immunohistochemistry. Or your lesion is small and you don't do microdissection to do NGS for dysplasia. Obviously, we need to be pragmatic. Then, like Corrado said, it's important to understand the pattern, different components in the same tumor, relation to the microenvironment. Obviously, the cost is another kind of important point.
Well, the cost, immunohistochemistry is the cheapest tool we have overall.
Yeah.
So, and for some of these questions we have on whether something is potentially a tumor or potentially dysplastic or potentially low grade, et cetera, probably the cost of sequencing, it's
depends how many companion diagnostic immunohistochemistry you need to put. Of course, disadvantages also is related to the sample, really, because one thing is to do on blood from a lymphocytosis and lymphoma, and then one thing is tissue, then again preservation, and the need to actually understand these patterns, which is very important for interpretation. I just put here a mention of the Lee-Fraumeni syndrome. I don't know how many people that breast is one of the earliest and manifestation, early breast cancer, then sarcomas and brain tumors as well. And now
finally, what we've been waiting for.
Finally,
yes.
Hope we have time to go through a little bit. Now, I put a slide for P53 and GYN, and I think this is interesting for diagnostic perspective as well. The first big fuss was in high-grade serous carcinoma, which basically is defining for high-grade versus low-grade. We know there are different molecular pathways. Low-grade is KRAS, BRAF mutations. High-grade is P53. This is a very important point in mucinous ovarian tumors, because the growth pattern is very expansile. It helps to kind of tilt the balance from mucinous borderline tumor to adenocarcinomas. Yes. And we have also in the vulva, more recently, the differentiated intraepithelial neoplasia that is basically defined by the basal pattern of P53.
Yes. So this is the dysplasia, if you want, intraepithelial neoplasia, which is independent from the papillomavirus.
From HPV. Yeah, and it's more common in vulva and cervix. We really don't see it as much. And just to mention that, now we don't make a lot of difference between endometrial cancers, but P53 mutation is presence of P53 mutation is part of the molecular classification and is seen in about 25% of endometrial carcinoma, I should said. And it's also useful for diagnosis, because if it's mutant and it has WT1, you think it's rather high-grade serous carcinoma of the endometrium rather than endometrioid carcinoma. And this is the schematic approach for molecular classification. Now, we need to be a point of being careful. We request these tests at the same time. So it's basically poly MMR and P53, but usually poly takes a bit longer. Now,
Yes.
presence of P53
Unless you
mutation.
work in Foundry, because you have it the next day.
Yeah,
Okay.
depends on the method of testing as well, because if you use NGS versus like like a
PCR.
PCR-based test.
Yeah.
But the problem is if you find P53 in the absence of poly, then the prognosis is the worst.
Yes.
While if the patient has poly mutation, that it doesn't have the same significance.
It doesn't matter if he has P53
Yeah.
mutation as well.
Because
Yes.
we regard it as a result, whether it is or not.
Can you go back on the first? So the important thing, while before it was more a matter of how much there is staining in the cell. Now it's about mutant and wild type pattern. It's no longer how many cells stain.
Yeah. I see.
Yeah.
Imagine if you are able to do NGS for all these cases, then it
Yes,
would
of
be
course.
much easier.
Yeah.
And
Okay.
then this is just an example to show the endometrioid morphology. And this is an endometrial carcinoma. This is a more glandular area, and this is a more solid. It's a bit serous, with serous-like features in places, perhaps.
And the P53 expression is wall to wall. It's very strong.
This is the missense pattern we always want to see, although we're not always that lucky. And this is actually a case from this morning that I had to check for molecular for NGS studies for poly. And this is actually carcinosarcoma. So we have the endometrial component to the right, and then the sarcomatoid component. And this is the most aggressive. But we can see that the mutation is throughout. So again, another missense pattern. I didn't have examples of other patterns in this. Now, I kind of lost this slide on the way. It went down as I moved the slide in my presentation. But these are the two special mutant patterns that we need to recognize and not call them wild type. I think that's the most important. And one of them is basal overexpression. And you see that a lot in actinic keratosis, but I like to put this because this is the vulvar differentiated intraepithelial neoplasia. This is from a paper that looked into these lesions. And the key is strong staining intensity pattern in the first one or two layers of cells that abruptly disappears. So it's just basally located. It's not typical wild type pattern.
Yes, because in a wild type pattern, you would expect, even if you have such a strong expression at the base, you would expect then a gradual decrease in staining intensity until then you lose it as you move upwards. But here is a step, from a lot to nothing.
And this is actually this terminal differentiation, which is not 100% clear why it happens, but you have a shift in the immunophenotype, really, of the superficial cells, and it just stops. The P53 expression stops abruptly. And this is actually a mucinous carcinoma.
So, I mean, we were discussing cases like this, and, we still have a lot to learn because our concept of how cells differentiate and move towards the more differentiated part of the epithelium is still not entirely well developed. And it is possible that the cells that are terminally differentiated don't come from the reserve cells that show that P53 mutation. So we still have a lot to learn about these odd staining patterns. We have another 12 minutes.
Yeah.
Okay. Dysplasia.
This is just the criteria for dysplasia that basically if you see block positivity, they say over 50% of the cells in at least one crypt, or if it's on the surface, which is basically the opposite pattern that we expect, is also evidence of dysplasia. And again, I mentioned this kind of terminal differentiation. And just a few examples, this was, so it was this focus on the H&E of, there was intestinal metaplasia here, but these cells were a bit worrying, hyperchromatic. And unfortunately, the section is significantly deeper here, but the intensity is not high. And we eventually, I think we said that this is possibly an indeterminate focus, but it has wild type expression. And then we weren't that worried. And then this is a example of dysplasia in Barrett's. And this case was difficult, and we did P53 because, as you can see, the top of the epithelium is gone for the most part. And we see here, this is low-grade dysplasia where there's no architectural complexity. The cells are still a little bit elongated, although hyperchromatic and atypical. And this is a P53, which I think here in this section, we get more of the surface epithelium. But there's also this focus. So there are two areas, one here and one here.
Yes.
And this is definitely, this could be more like crypt dysplasia because we still have a lot on. And here you see the contrast between this is wild type because the intensity is low and you see some of the cells are negative, and this is the mutated
and
component.
this focus is now, obviously, interpret with caution. The fact that you have this doesn't mean there is high-grade dysplasia. You need to marry this with the morphological features. You know?
Otherwise, you would call it UCIC P53 expression. This could mean a risk of progression that is higher,
Indeed.
and then get on with it. And again, P53, so the gastric carcinoma and endometrial are two of the tumors that use P53, could use P53 for classification, and then the poly of the gastric, EBER. And then we do mismatch. And then plus EMT markers.
So let's open a little parenthesis, because you see, in the classification of, at the moment, adenocarcinoma, but it will not stay only with adenocarcinoma, there is the concept that one category, because now the categories start to make homogeneous sense. You know, there are these tumors that have not a lot of mutations. There are these tumors that have they are hypermutated. There are these tumors that are super mutated. And the P53 helps identify these genetically unstable tumors. Seems to be a good marker, surrogate marker, to stop you doing, you know, whole exome sequencing to understand whether there is chromosomal instability or not. And this is reproducible in a number of tumors. So more and more, the use of P53 will become a part of the genomic classification, molecular classification.
Yeah, and this is kind of, if we go down this line, this case illustrates this. This is actually your case, and you've done all this. Is MMR proficient, is positive for E-cadherin, beta-catenin, P53 mutated pattern. Again, makes sense. The rest is just tumor stroma.
Yeah.
EBER was negative.
Negative.
Put it at the end, unfortunately.
So you chromosomal instability, yes.
Just a note about neuroendocrine neoplasm, because there is a tendency amongst pathologists to call everything that is mitotically active low-grade, large cell neuroendocrine carcinoma, but we should not forget about grade 3 neuroendocrine tumors. And P53 can help with this, especially when morphology is difficult to interpret, because NETs are rarely P53 mutated, while large cell, the mutation is very frequent.
If they don't have mutation, they could still be a large cell. But if they have mutation, the diagnosis is more easy.
Even in grade 3 NET, P53 mutation is possible, but rarer. And then
skin tumors, yes.
Of course, P53, one of the injurious elements is UV exposure. And squamous cell carcinoma, for instance, the P53 mutation is very common, and all the sun damage related lesions. This is another example of basal pattern, isn't it? And in an actinic keratosis, and we clearly see dysplasia here.
Isn't that interesting? You see that there is a gap in the follicular infundiculum.
Yeah, it is, but not always, because sometimes you see all around. So it depends on the type of actinic keratosis, whether it's more proliferative, whether it's more conventional like that one is. And here, this one is a bit more subtle. It's almost like you could think, could this be a flat wart with some viral changes? But I think the P53 expression, and then if we look carefully, we see a mitosis here. The cells are enlarged, and I think this could be diagnosed. This is another actinic keratosis, actinic keratosis. They're both sun damage induced. They have risk of SCC, so it doesn't matter. But this looks more like, I'm not sure, is it overexpressed? Is it mutant?
Yeah, okay, this is difficult to interpret.
A bit difficult to interpret.
There are cells that have preservation of strong staining, and they go almost at the top, almost at the granular cell layer. So maybe,
Maybe.
obviously is not very important. It's not an invasive tumor, etc., but nevertheless.
Yeah,
Keratoacanthoma.
Yeah, this should have this morphology, like on the left is more regressed. This is more
active,
pale cell proliferating.
Yeah.
But if we go on P53 high power, it's the same wild type pattern. Okay, here is a little bit more intense, but there are cells that are not staining even around the base. So for me, this is not some sort of basal pattern. And
okay, so how does this
SCC.
influence you in differential diagnosis between keratoacanthoma and squamous cell carcinoma?
Personally, it doesn't. But if you find the P53 mutation, then you have this in mind that, I don't know if this is P53 mutation associated with a proliferative or more florid keratoacanthoma, or this is some evolving thing.
You could have P53 mutation in keratoacanthoma, but if you find P53 mutation together with other parameters, you feel maybe I should veer towards squamous cell carcinoma rather than keratoacanthoma.
It is.
But if you find absence of mutation, maybe it's less common in squamous cell carcinoma, so maybe you are more steering towards keratoacanthoma in the correct settings.
Now, this one, again, this doesn't have the special cytology of keratoacanthoma entirely. The cells are more like eosinophilic, not very glassy, and it's quite complex. And also this pattern with P53 is almost like all the way around. So maybe, for me, this is a well-differentiated SCC. And I really wanted to show you this. This is another crateriform lesion that is P53 mutated, but it has this nice
mutant pattern,
cytoplasmic and nuclear.
Yes.
And should we stop the question?
Oh, good.
No, we have another 4 minutes.
And then this is to show that actually you don't have the background cytoplasmic staining.
Yeah. Okay, so we have is there a lot? Atypical fibrous anthoma, that's an important consideration, because I think when you want to make an AFX diagnosis, really you should make sure that there is P53 mutation. That goes hand in hand.
Yeah.
If you don't have P53 mutation, think carefully. But this you were going to show a nice case where P53 was helpful.
So this is also a missense pattern, but not 100% of the cases have it. And this is just to show that it can help with the margin assessment, because this is a bit not very clear. It's very inflamed.
Yeah.
And then we have this P53 mutated pattern. And then I have other examples, but I don't know if we can.
Okay, well, we stop here. There are 1 or 2 questions. One is about is P21 staining a useful adjunctive to indicate presence or absence or upregulation of non-mutated P53? Yes, I think it is. P21 is not an immunostaining that many people have at their disposal in the laboratory. So, but yes, absolutely, it's a good point, Richard. Should we do P53 on all squamous proliferative lesions when we are looking between differential diagnosis of squamous cell carcinoma and keratoacanthoma? The reality is no, because the reality is that is it really important? If you have a lesion that is completely excised, does it really matter that is a well-differentiated squamous cell carcinoma? Yeah, maybe there is a bit more follow-up to do. You not always will be completely certain of your diagnosis. So it's often this differential diagnosis often is an academic entertainment more than a real diagnostic problem. And by the way, it is interesting that nowadays, I mean, I remember 20 years ago, if we got a keratoacanthoma-like lesion or a keratoacanthoma, we would all show each other. I mean, we would maybe see 1 every 2 weeks or every month. And nowadays, we see 4 or 5 a day. And that's because I think, that's my conjecture, is because somebody has a squamous proliferative lesion that looks like a squamous cell carcinoma, is referred for removal. The removal occurs 4 months later, at which point we have regression, because this was not a squamous cell carcinoma, was in fact a keratoacanthoma.
But also to think that only keratoacanthoma regresses. I mean, there are patterns for sure in squamous cell carcinoma that would regress.
That would regress, yeah.
We don't
Few
understand
more,
clearly.
few more questions. Is more important a mismatch repair in young keratocantoma does not cautiously call well-differentiated cell carcinoma? Yes, and I think this is more, Richard, this consideration is more important. In those practice, they do a lot of shaves. So basically, you still have most of the lesion left over, and then you need to tell them you should remove or not remove.
I think he's mentioning the fact that you wouldn't see normally, like in younger patients, this kind of lesion, and it's good to screen with MMR. For
So,
Lynch.
Eleni, the P in Barrett's esophagus, the thing I found most useful in Barrett's to assess dysplasia is presence of P53 mutant pattern, because it kind of rules out in my mind that I'm looking at a reactive inflammatory esophagus. I'm not so sure that I would use it. It would be the only thing I use to differentiate between low and high grade dysplasia. I think both of them probably are P53 mutant.
Yeah, like we said earlier, low grade dysplasias can be mutant or can have wild type pattern, and it doesn't rule out. You can see including loss or other strange missense loss pattern in low grade dysplasia and Barrett's. For sure.
There is one last question. I know we are a bit over the hour. On surgical specimen, when a tumor showed zones of intense P53 staining and zone of weak or moderate staining, do we attribute this to pore fixation or to subclonal overexpression? And that I do not know, because obviously the pore preservation of tissue, large specimens, it's obviously
I would interpret in context like we do it sometimes with MMR or other immunohistochemical markers. If it looks like it's from
very good
fixation, then
fine. So thank you, Ade, for this. I know you have a lot of interesting things to show us. This is a follicular cystitis. These are all interesting things, because actually the two big areas of confusion in my head is bladder epithelium, is there dysplasia or not, and esophagus, with Barrett's, and if you're not careful, you end up with a esophagectomy, and then you don't find anything in it. So those are diagnoses that matter a lot. And yes, and P53 I think is a very, very important weapon in our arsenal. And I'm sorry that we run out of time. Just to remind everybody that on the 22nd of October we have a P16 educational session only. I think P16 is another very important molecular tool for us. And then on the 29th of October, the PT round for folate receptor 1 starts, and that is in endometrial carcinoma, ovarian carcinoma. Very good, 29th of October.
And there's HER2 and D-dish running now.
And just now there is HER2 and D-dish, but obviously you all know, and we're all tired of HER2 and D-dish. Anyway, so thank you all very much for listening to us, and we'll see you next month.